resorption. Light chain AL amyloidosis may also form, involving the renal glomeruli with the vessel wall, and bacterial pyelonephritis secondary to increased susceptibility to bacterial infections will also occur due to hypogammaglobulinemia. And rarely interstitial infiltrates of the neoplastic plasma cells are also seen. And in contrast with multiple myeloma, lymphoplasmacytic lymphoma, which we will discuss, is not associated with lytic skeletal lesions. So lytic skeletal lesions are strongly associated with multiple myeloma, and mostly it is broadly around the whole skeleton. So in contrast with multiple myeloma, lymphoplasmacytic lymphoma is not associated with skeletal lesions. Instead, the neoplastic cell diffusely infiltrate the bone marrow, lymph nodes, spleen, and sometimes the liver. Infiltration of other organs is also a possibility, and the cellular infiltrates consist of lymphocytes, plasma cells, and plasmacytic lymphocytes of intermediate differentiation. So after discussing the pathogenesis and morphology of multiple myeloma, let's briefly recap what we have understood up till now. Is that multiple myeloma is the malignancy of the plasma cells. Okay, it's dependent upon IL-6 secreted by macrophages, and IL-6 is required for myeloma cell proliferation, and then excess production of the immunoglobulin will occur in the multiple myeloma. So again, about the antibody secretion in the multiple myeloma, that primarily IgG is secreted followed by IgA, and then light chains can only be secreted in the multiple myeloma. So together IgG, IgA, or only light chains, when they are secreted, we will just use the term paraproteins. So if we can see that how light chains are made, so basically each antibody contains two identical light chains, which may be either kappa light chain or lambda light chain. And also the antibody is having a heavy chain, and heavy chain type determines the antibody type, that whether it is G, A, or E, etc. So light chains are usually filtered by the glomerulus, and it is resorbed or reabsorbed in the proximal tubule of the kidneys. So in multiple myeloma, light chains will start appearing in the urine, and it will be called Ben-Jones protein. So excess light chains secretion in the urine can occur in the multiple myeloma, as well as excess light chain leads towards pathology related to renal damage or AL amyloidosis. Now SPEP, which also stands for serum protein electrophoresis, uses that electric current separates serum protein. So in SPEP, electric current separates the serum protein based upon size and charge. So in myeloma, we will find that characteristic M spike having that gamma fraction immunoglobulin when it is secreted in excess, so it will create an M spike. So in normal SPEP, you will find a peak of albumin. However, the gamma globulins will not be peaked. But in multiple myeloma, alongside the peak of albumin, you will also find a peak of gamma globulins, and hence a characteristic M spike will form in multiple myeloma. So clinical features of multiple myeloma are bone pain or fractures, hypercalcemia, renal failure, anemia, and infections. So again, we will just briefly touch about hypercalcemia. So it is basically an osteoclast mediated bone resorption occur in the multiple myeloma, which is caused by the cytokines from the myeloma cells. So myeloma cells are secreting the cytokines, as we have discussed in the pathogenesis of multiple myeloma, and what they will do, that they will increase the expression of frank ligand, and hence osteoclast mediated bone resorption will start occurring, and it will form that characteristic lytic lesions on the X-ray, which is also called punched out lesions. So most commonly vertebral column is involved, however other side of the skeletons are also most frequently observed. So what will happen when osteoclast mediated bone resorption will occur? We will have increase in serum calcium and hence hypercalcemia. So renal failure in multiple myeloma, as we have discussed, that there are multiple factors of the renal failure in the multiple myeloma, and one of this is the deposition of the immunoglobulins. Then there is increased chances of infection in the multiple myeloma. So at multitude of areas the kidney is surrounded and it is just trying to damage the kidney on every end. So light chain deposition, increased chances of infection, bacterial pyelonephritis, as well as hypercalcemia. So these all three factors when just come together, so that is just like an assault on the kidney. So light chains deposition is also known as myeloma kidney. So as we have discussed previously, that small amount of light chains are normally filtered and hence is reabsorbed in the proximal tubule. But in multiple myeloma, proximal tubular capacity will exceed it because a lot of light chains are secreted in the or filtered in the kidneys. So what will they do? That light chain will reach the distal convoluted tubule, and there it will combine with Horsfall mucoprotein and will form obstructing casts. And when these casts will start appearing in the urine, we will just say that it's a Bence-Jones protein. So two different things. M protein. What is M protein? It's increase in the gamma globulins or IgG, IgA, IgE, whatever the antibody it is secreted by the plasma cells. And the second is Bence-Jones protein, which is the light chains when appear in the urine. We will say the Bence-Jones protein, and M spike and Bence-Jones protein is a hallmark feature of the multiple myeloma. Then there is increased hypercalcemia. When hypercalcemia occurs, we know from our medicine lessons that it impairs the renal ability to concentrate the urine, and hence polyuria will occur and volume contraction will occur. So hence dehydration will occur, which will just decrease the GFR, and hence it will prove fatal to the kidney. So urine dipstick, the normal urine dipstick is usually negative for the protein in the multiple myeloma, because that normal protein dipstick test usually detects the albumin. However, it poorly detects that light chains. So that's why normally in multiple myeloma, if you are just measuring the urine protein through that urine dipstick test, you will find it negative. However, you have to use another much better test, which is known as urine protein electrophoresis, just like SPEP. So that will detect that Bence-Jones protein, and which are basically the light chains. Then serum free light chains, like it's also a blood investigation antibody based system, and it's sensitive test for serum kappa or lambda light chains. So you also can order this test, serum kappa or lambda light chains, and you can find out in the serum that whether these light chains are present or not. The anemia most commonly found in the multiple myeloma is the normocytic normochromic anemia, and as it is expected, because when kidney will damage, so what will happen, that the erythropoietin secretion will be at halt. So when it will be at halt, so what will it do? That erythropoietin will not secrete it out of the kidney, so we will expect the normocytic normochromic anemia. And weakness pallor can also be the only presenting signs and symptoms at the onset of the diagnosis of the multiple myeloma. So infections is the leading cause of the death in multiple myeloma, because there is decreased production of the normal immunoglobulins. So when there is decreased production of the normal immunoglobulins, the immunoglobulins are produced in the multiple myeloma, but they are not normal. So you can expect the recurrent bacterial infections just like strep pneumonia, Staph aureus and E. coli type of infections are most common in multiple myeloma. Then there is also Rayleigh formation, in which RBCs form a stack of coins, and it is caused by elevated protein levels in the plasma. So you will find the stacked coins on microscopy, and you will find that Rayleigh formation, which is occurring in the multiple myeloma. So SPEP will diagnose monoclonal protein, but the diagnostic for definitive diagnosis, definitely you need the bone marrow biopsy, in which you will see the clonal bone marrow plasma cells. And second most important thing for the diagnosis is the end organ damage. These two factors, when combined together, you can say that yes, it's definitely multiple myeloma. So another variant which we had discussed right in the onset of the podcast was MGUS, monoclonal gammopathy of undetermined significance. It's an asymptomatic plasma cell disorder, abnormal SPEP due to presence of M protein. However, there is no end organ damage. So it can progress to multiple myeloma. So it's just like an asymptomatic plasma cell disorder. However, you will have no end organ damage. So it's just like it's often detected when you are doing workup of any other problem, and you will find out anemia, hypercalcemia, or bone pains, but it's not that full-blown multiple myeloma. Then a word about Waldenstein macroglobulinemia, which is also called lymphoplasmacytic lymphoma. It's a sort of B-cell lymphoma, and tumor cells differentiate into the plasma cells, but they will produce excess IgM. So IgM is a large antibody, and it is produced, and it will form that pentamers, and when it forms pentamers, what it will do, it will lead towards that classical hyperviscosity syndromes. So Waldenstein macroglobulinemia is also plasma cell malignancy, but the most common antibody secreted in the Waldenstein macroglobulinemia is IgM antibody, and it will lead towards the hyperviscosity syndrome due to the presence of that pentamers forming in the IgM. So what you will expect in the Waldenstein macroglobulinemia is the weakness, fatigue, weight loss. You can also find lymphadenopathy, but there are no osteolytic bone lesion like in the multiple myeloma. So you will also find that M spike on SPEP, but that M spike is from IgM, as contrast to multiple myeloma, in which IgG are the primary antibodies which is secreted in excess. So difference between Waldenstein macroglobulinemia and multiple myeloma is the presence of the antibody. Like in Waldenstein, you will find IgM antibody, or in multiple myeloma you will find IgG. Both are having M spikes, but the hyperviscosity syndrome is most likely associated with the Waldenstein macroglobulinemia. So basically, IgM increases the viscosity of the blood, and the blood flow will be sluggish and sludging will occur, and you will expect the CNS symptoms like headache, dizziness, and coma, or usually visual impairment can also occur in such patient population. So you have to treat it with emergent plasmapheresis. So this concludes our podcast for the plasma cell disorders, and specifically multiple myeloma.